So lastly, we'll see about gestational trophoblastic diseases. So gestational trophoblastic diseases, you must have heard of the name H mole or hydatiform mole. So these are nothing but grape-like vesicles. So on gross, if you see, there will be grape-like vesicles. So these are all translucent vesicles which appear like grape, right? So multiple these grape-like vesicles will be seen in these H moles. So H mole is usually divided into partial mole and a complete mole. Partial mole is when you see the fetal parts. So in gross examination, you will see these grape-like vesicles. Along with that, you will get some parts of the fetus also. So fetal parts will be present in partial mole, while fetal parts will be absent in a complete mole. Then there is going to be increased risk of transformation of this complete mole into choriocarcinoma. So there is going to be 2.5% of risk of cancer in complete mole, while partial mole doesn't have any risk of cancer. So what is the genetics involved in developing this partial and complete mole? Suppose there is a ova which has 23 chromosomes. So there is a sperm which is coming. So usually it is either 2 or 3 sperms which are going to fertilize this ova. So each of the sperm is going to contribute 23 chromosomes. So normal is when the ova is contributing 23 and one sperm is going to contribute 23. So total 46 chromosomes will be present in the zygote. But in this condition, it is going to be 2 or 3 sperms which are going to fertilize the ova. So there is going to be 4 sets of chromosomes. So if 2 sperms are going to fertilize the ova, it is going to result in a triploid status with 69 chromosomes. Or if there is going to be 3 sperms which is fertilizing this ova, then it is going to result in 92 chromosome, which is tetraploid. So this kind of thing is going to be seen in partial mole, while in a complete mole, there is 23 chromosomes in the ova, but this 23 chromosomes in the ova is going to be lost, and a single sperm is only going to fertilize it. So there will be 23 chromosomes only. But what happens is this 23 chromosomes which are present in the sperm are going to duplicate and form 46 chromosomes. So it is going to be normal like a diploid. So complete mole will have a diploid status with 46 chromosomes only, but as such the ova which is have the 23 chromosomes, the ova is not going to be there. So the entire chromosome set is going to be acquired from the paternal origin. So from the father, the entire chromosome is going to be derived. There is no maternal chromosomes. So that is why P57 is going to be negative. So P57 is going to be maternal. So P57 will be negative in complete mole. So in invasive mole, it is nothing but the molar gestation like this only. It is going to invade. So as the name says, it is going to invade either the vessels or the myometrium. So you can comment only when you get a hysterectomy specimen, and this spread and it can also spread to the lungs, vagina, and vulva. So microscopically, if you see, there will be lots of trophoblastic proliferation, and these trophoblasts will show atypia. But there will be formation of villi also. So the normal villus will also be present. Apart from that, there will be trophoblastic proliferation and atypia in invasive mole. So all of this can transform into a choriocarcinoma. So choriocarcinoma can be either a placental origin or from the ovarian or testicular origin. Okay. So the placental origin choriocarcinomas are going to be kind of mild, while the gonadal, which is ovarian or testicular choriocarcinomas, are going to be quite aggressive. Okay. So now we are dealing with, now this choriocarcinoma I am dealing with is the placental choriocarcinoma. Okay. So the placental choriocarcinoma can originate normally from post a normal pregnancy also, post an abortion also, or post a hydatiform mole also. So 22% of the normal pregnancy can progress on to choriocarcinoma, and abortive tissue. So 25% choriocarcinoma develops from abortions. Then choriocarcinoma can develop from complete moles, and that is contributing the maximum. That is 50% of the complete moles can progress on to choriocarcinoma. So the risk associated with complete mole was 2.5%, right? And choriocarcinoma, it is going to have lots of hemorrhage and necrosis. This we had already seen. And microscopically also, it is going to be a triphasic or a biphasic tumor in which there is going to be sheets and sheets of these trophoblastic cells, which are composed of cytotrophoblastic cells, in situ trophoblastic cells, and also intermediate trophoblastic cells. Okay. So these cells are going to be there. Along with that, there is going to be lots of necrosis and hemorrhage. But the most important point is there is going to be no villus formation. So these trophoblastic cells which are proliferating are going to show atypia like an invasive mole. But in invasive mole, you can still see the presence of villi. But in choriocarcinoma, there is going to be no villi formation. So tumor markers and also serum biomarkers, and then immunohistochemically also you can use beta HCG to confirm its origin. And this beta HCG levels will be monitored serially also. So any choriocarcinoma is going to be chemosensitive. So can give methotrexate therapy, and then they'll keep the patient under follow-up. So during follow-up, they'll be measuring this serial measurements of beta HCG. So when this beta HCG is falling and suddenly it is rising, then it means that there is some metastasis or the tumor is growing back again. So the most common metastasis of choriocarcinoma is going to be the lung or brain.